Thank you very much, Alex. It is a pleasure and an honor to be invited and talk in this university. A warm welcome to everyone. It's the first talk of the day. I'll try and be a little bit brief, and we're going to discuss in the next 10-15 minutes about the role of negative wound therapy in thoracic surgery. If we look a little bit at the historical aspects, negative wound treatment has been presented in the 90s, and there are a few points that you need to take from this slide. It didn't start with thoracic surgery, it started with general surgery, plastics, and orthopedics. And Moriquas, he did actually a presentation and a publication in the Annals of Plastic Surgery in 1997, and on animal studies. He actually proved that overall negative wound therapy is beneficial, but the specific points that he made was that a negative pressure of 125 millimeters of mercury increased essentially the blood flow, so it enhanced recovery. But when you went into negative pressures of more than 400 millimeters of mercury, there was a reduced blood flow. The second element from this study was that we had granulation tissue formation, which is extremely important. So you don't only have neoangiogenesis, you do have some granulation tissue formation, and it was actually quite high with both continuous and intermittent application of negative pressure, and they suggested that the intermittent negative wound pressure is better than the continuous one. They've also showed that the negative treatment, or the VAC pack treatment, as I would call it, it has bacteriostatic benefits because the constant vacuum essentially sterilizes the wound. We've seen in 2006 actually the first essentially publication that showed the benefits of the VAC pack treatment. This is a case from VAC and Kimberly where they managed an emphysema cavity on a patient that had a lung resection and a chest wall resection with VAC pack, and this is the end result. The interesting thing is that they never had to go back and reoperate this patient. More publications came out slowly. The vast majority of them are small series. In Leeds, we started utilizing this technique approximately 3-4 years ago, and we collected a small number of patients which we presented in STS in 2012. If you look at this slide, our initial experience was a potpourri of cases. So it gave us initially the opportunity to see how the negative wound pressure treatment actually works. So we had people with lung resections, all types of lung resections, people that had sternal resections, or people with resection of mediastinal masses, and the vast majority of them, they had cavities that they were infected, and we had problems with them postoperatively. Our initial flow chart was obviously to offer all these people an open drainage and debridement, followed by the VAC therapy system, either directly intraoperatively or after 24 hours. And then we used to change the dressings every 2 or 3 days and discharge patients home when they had the ability to have the VAC pack dressings changed with local anesthetic, and they didn't need to go to the OR. What we found beneficial was the fact, obviously, that these people could be managed after that in the community, so we could release beds. Our initial results showed that we had no reports of pain or discomfort associated with the VAC system. The most important thing for us also was the social embarrassment that people do have if they have different types of treatments, when they have colostomy bags attached to them, when they have drains with Portex bags. This is a more socially acceptable device in the community. 2 of our patients actually went back to work with a VAC in situ, and we required to have 1 revision, and we had 1 death, but there were complications which were not related to the VAC treatment. When somebody looks also at the cost, I think in this country it could be beneficial. If we look at studies, they've showed that the VAC-dressed wounds, actually, they do shrink much faster than if you just simply pack them and change the packings. And if you look at the overall cost, although this is supposed to be an American study, the VAC therapy had a cost of $14,000 average, with a traditional one $23,000, and the VAC therapy healed wounds 61% faster. When we looked at our cases, and we're not really biased because we have used all commercially available systems, so we don't like one specifically, and we don't promote any one of those ones specifically. I have to apologize, this is a little bit of a busy slide, but what came out for us, it was that we had an average weekly cost for pumps, dressings, and canisters between $230 and $260. Here was $330 and $360. A similar price, around about $250, was for the third system, which means that one night of hospital stay balanced out, essentially, the cost of a whole week's treatment on patients that could have gone home and been managed at home. Then we started thinking a little bit more wider. After done the first 10 cases, how do we manage the complex space? And I put a list down of things that all of us as thoracic surgeons, we might be doing. You manage a complex space that has an infection either with tube thoracostomy or a fenestration with or without dressings, or radical maneuvers like a thoracoplasty or a VAC pack treatment. But when you start looking at the space management, there are a myriad of things that you have to keep in mind, isn't it? Do you have an infection or not? Where is the management of this patient going to take place? What are the associated costs? Do you have any special circumstances? What is the position of the problem? What is the size of the space that you have to deal with it? What are the cosmetic results and the outcome you want to have? What is the pathway complexity? And all sorts of other things. And if we look at the different techniques that have been used, I hope that you all of you agree with me today that a tube thoracostomy is something that we used years and years ago, and it's something that we must not use today. It doesn't address any of the problems, and it doesn't solve any of the problems of the space management. It's one way of sending somebody home, but it's almost like buying time, and you don't do any definitive treatment. If you look at the fenestration with or without dressing changes, some of the elements, they can be dealt with, infection or a bronchopleural fistula, and no soiling on the contralateral lung. But if we look at the rest of the aspects, I think we still have problems. The radical maneuvers, I don't believe very much myself in thoracoplasty unless somebody is really desperate, and I don't think that we need to do thoracoplasties nowadays. And this is where I thought that the negative wound therapy offers everything that we would ask for. It can deal with infection. It can place a patient in the community. It can deal with any kind and any size of space that you could have. It has very good and acceptable cosmetic results. It does make the pathway of those patients less complex. It is comfortable for patients, and obviously it is socially accepted. It doesn't require much of compliance, and you can deal with other problems like an associated bronchopleural fistula. We have then gone on to produce for ourselves a flow chart in a way that we manage patients nowadays that they do have complex infections or complex spaces after surgery, and they require a VAC pack treatment. One of the challenges that we always had was obviously the presence of bronchopleural fistula, because you are running against a leak, and that can be a problem. We then decided to divide those leaks into proximal and distal ones. If you have a low lobectomy, for example, with a distal leak and lung coming down with gravity onto the diaphragm, your leak might not be that large. And then, depending on how the wound looks like and whether you do have an evidence of granulation or not, you can decide either to continue with a VAC treatment, but if those patients show that their wounds are shrinking and their nutritional status becomes better, the VAC pack becomes step one, followed by a muscle flap closure when the cavity is ready to be obliterated. If they do have a proximal bronchopleural fistula, we found that the VAC pack is a problem. In that situation, you have to at least reduce the air leak that you do have. And in this situation, we have, in a few patients, placed stents, not as a permanent solution, but in a way to successfully reduce the air leak. If you were able to do that, the negative pressure wound treatment would be sustainable, and it would work. If you still have a large air leak, then obviously you have to revert into an open wound treatment. And coming into patients that they might have lost a lot of soft tissue as with or without a lung parenchyma, then obviously we have created ourselves a flow chart. If we have had patients that they might have had complex chest wall resections and we had problems in actually covering those large areas, the VAC pack treatment might be an interim solution before you actually do anything else into these patients. If they don't have any parenchyma resection and there is no disruption of the visceral pleura, so you have no air leak, you just give them a standard negative pressure wound treatment. In some of these patients, you don't even need to go back and operate them again. If they do have some visceral disruption, then you will lower the negative pressure and review. And then if they have no symptoms, then you're going to go back into giving them the standard negative pressure, which is between -75 and -125. For those that they did have a lung parenchyma resection, we have an intrapleural space, which is an issue as well. And if they have an associated infection, then we would look at the size of the space. If they do have an pneumonectomy space, which is a large one, sometimes 700, 750 mLs, then you will give them a lower negative pressure until you reduce the cavity. In some of those people, you can actually insist for 6 to 7 months, and the cavity can reduce to almost zero without needing to be reoperated. Now, for those that they have a partial lung resection, a wedge, a segment, or a lobe, if they do have an emphysematous lung, we will give them a continuous negative pressure, but not very low. And the reason for that is because we wanted to make sure that these people will not pop a bulla and end up with a very large leak. We do not agree on the intermittent negative pressure. We like continuous, because we believe that with the intermittent one, you have constant cycles of high and low negative pressures, and you can introduce an injury to the lung. For those that they have non-emphysematous lungs, we will give them a standard negative pressure wound treatment up to 75 or up to 125 millimeters of mercury. Our conclusions, we think that VAC therapy is safe. It has minimal discomfort. It's much easier applied on a patient. It is much easier acceptable from patients. You can change the dressings without any anesthesia after you do the first 3 or 4 changes after a week approximately. It does promote early rehabilitation. It does reduce hospital stay, because all that can be managed in the community with a little bit of training of the nurses. And obviously it allows the patients to continue with the activities of the daily living. In the vast majority of patients, it reduces the need for a second procedure. You can essentially obliterate spaces entirely if you wait long enough, and we believe that it is cost effective. And with this, I would like to thank you for your attention.